Hello everybody and welcome to another webinar organized by Ophtec. My name is Thiago and I'm the Global Marketing Director. Today we're going to talk about challenges in ophthalmology. We're talking about astigmatism, we're talking about presbyopia. And we have a good mix on our panel with some experienced surgeons, but also some young surgeons. We will have today, at the end of the day, a special guest, Dr. Harris Mulder from Tallinn, Estonia, who has had implanted a precision presbyopic on his own eyes. So we'll have the perspective of a surgeon that became a patient. So it will be interesting to hear what he has to say. Furthermore, I would like to tell you that there are some questions coming during this webinar, some pool questions that you will be able to answer. So give us our opinion about the different topics. First of all, I would like to welcome Dr. Korkmaz from the Netherlands, who is here next to me in Amsterdam. Dr. Korkmaz.
Yes, I kindly thank Ophtec to give the opportunity to be a moderator of this really nice webinar. And I hope we all the viewers and all the competitors will have a fruitful webinar where we can share our knowledge and learn from each other in difficult and less difficult cases. So I'm really looking forward to see the presentations of my colleagues in the rest of Europe and hoping to learn a lot from them.
Thank you. I have to say I appreciate very much Dr. Korkmaz for several reasons. Is a very high volume surgeon here in the Netherlands. I think he probably does the most number of premium IOLs in the Netherlands at this moment. And he has also done something that you need some kind of courage to do. He actually implanted a precision presbyopic in our CEO, Erik Jan Vorst. And I can tell you they're still friends. So I think we have a happy patient and a happy Dr. Korkmaz.
Yes,
maybe you'll tell us more about that later on. Yeah. So furthermore, we have 3 more speakers, which I will tell just a little bit about them. Professor Filomena from Lisbon. She is based on Hospital de Luz, where she is the head of the ophthalmology service, but she's also busy by being a board member of the Portuguese Ophthalmic College, but also a board member of the ECRS. And a few months ago, she became also an editor of the JCRS journal. So I'm happy that she's doing all these things and she still has some time to share with us her knowledge with this webinar. From France, we have a young ophthalmologist, Dr. Camille Bosque. He's an expert in anterior segment and he's at the Jules Verne Clinique in Nantes. So we're very excited to hear about his astigmatism cases and how he treats complicated with irregular astigmatism patients. We have also Dr. Holland from Germany, and Dr. Holland is a refractive and a cataract expert who is one of the founders of the GERSO Society, together with well-known names such as Professor Sunil Shah or Florian Kretz or Gatinel. And he just opened up his new clinic in Kiel, Germany, and he's going to tell us all about how he treats his astigmatic patients and what is the workflow to get the best results. So I look forward to it, and without losing any more time, I would like to welcome Dr. Holland, and please be so kind to tell us. I think you are mute, Dr. Holland.
Oh, sorry for that. So,
no problem.
Hello, thank you for this kind invitation. Thanks to Ophtec and for giving me the opportunity to share with you my experience with the precision toric and talk a little bit about our workflow that we have in our practice and clinic. 1 second, I have to start the presentation here on my laptop. So I hope you can see my first slides. Next, please. everybody know, we have a large number of patients in our normal cataract population who could benefit from a toric IOL. But if we come to the next slide, please, we can see that we have a look on the premium IOL market, for example, in Germany. We see that there is only around 3% of toric and multifocal IOLs. So there's a large population of patients without the best possible surgery. And we often ask ourselves, why is that? Is it because of the costs? Is it because of the organization in the office and our clinics? Is it because of the supply of diagnostics in the clinics? Or is it about the fear of unhappy patients after premium IOL implantations, about all these discussions that could happen after an implantation and in an unhappy patient? Or are there any other causes for that? Next slide, please. So what is our experience in our daily life? I think it is much easier to implant toric IOLs in our daily routine, as most of the colleagues think about. I think if we use easy and modern technology, it allows us to use toric IOLs in a perfect way with good clinical outcome. So we started a study which will be recently published with the help of Ophtec. And we had a study design. We used, it was a prospective study. We had ethic committee approval. We planned 30 patients with cataract, and they had to have a regular astigmatism above 0.75 diopter. Exclusion criteria were other pathologies. We used for the biometry the size IOL master 700, and for the topography the Cassini. And for the marking of the implantation axis, we used the RoboMarker. So the topography with Cassini is very easy. The Cassini uses a special LED technology with over 600 colored LEDs for ray tracing measurement. And what is very well in this tool is that we can measure the anterior and posterior corneal astigmatism, which results in defining the total corneal astigmatism, which we always used for the calculation of the toric IOL. For the marking, as I told you, we used the RoboMarker from an American company. It's a handheld marker. It's self-leveling. It has an integrated fixation light, which makes it very easy for the patient to hold the eye very calm for the marking. It is comes with pre-inked and disposable tips, and is very easy to use with a small, very short learning curve. The design of the Precision Toric is, it's a one-piece IOL. It has a optic of 6.0 millimeter and a conic toric and biconvex optic. It's a hydrophilic acrylic material. The total diameter is 12.5 millimeter, and it comes from 1 diopter to 34 diopter, which so it's a large number of IOLs available, and comes from 1 to 10 diopter for the torus. And as you can see in the picture, the C-loop, double C-loop haptic is very working very well with shrinking of the capsular bag, so the IOL really remains in position. Next slide, please. Here you can see the optic design a little bit more. It has a aspheric toric anterior surface and a aspheric posterior surface. So next slide. The injector which we used was the injector from Ophtec. It's a very easy to use injector, and it gives sorry, no, I'm wrong. No, this is correct. Very easy.
Medicell.
Also used very often in premium IOLs in this study. In every patient, we use a capsular tension ring, also from Ophtec. Next slide, please. As you can see here in the on this slide, this is a special thing of the Optic Design. You can see that the part of the optic which corrects the torus, it's much larger or wider than in a standard toric IOL. And this leads, next slide please, to a constant correction of the spherical equivalent and the torus over the whole optic. And this, next slide please, design leads also to more pupil independent correction in comparison also to the standard toric IOL. So even if the pupil is wider, for example, in night driving, the correction of the toric of the torus is very pupil independent, which also leads to a better visual acuity and better visual quality, also in mesopic conditions. Next slide, please. So why is this design so excellent for toric compensation? We all know the problem of misalignment if the toric IOL is not in axis. So 6 degrees, for example, leads to 20% undercorrection, and the larger the misalignment is, we can also have a fully loss of the compensation of the astigmatism if we are, for example, above 30 degrees. Next slide, please. So if the precision toric has a misalignment, it leads to a lower loss of compensation of the astigmatism than a standard toric IOL, which you can see here on the slide. For example, if we have a 10-degree misalignment in the precision toric, we have only 16% loss of compensation compared to 30% in a standard toric IOL. And this, for sure, must lead to better post-operative outcome. Next slide, please. So what is also important, not only the toric IOL, but also the preoperative planning, and where we focus much on in our practice is dry eye, because a lot of German patients have dry eye disease. On average, the cataract patient is around 70 years old. So we very often see dry eye disease, and we all know that there is an interfering in the topography and biometry. So we always make a very good a preoperative diagnostic for the dry eye disease, and we use the IDRA for this, which is a very fast and sufficient device. And if there is, for example, a meibomian gland problem, then we also treat the patient in advance with light therapy. We use the EI, which is very easy to use and which results in very good decrease of dry eye symptoms. Next slide, please. So we also repeat the examinations. It's very important that you have a very good staff that learns to read the data that they produce. With the devices here, you can see a regular astigmatism, and only some minutes later, next slide, please, you can see that the topography looks totally different, and that's very important. We have to repeat the examinations, and we have to have staff that really can read it and can really know what they are measuring. Next slide, please. So it's very important also to have a second appointment, if possible, because if we have a high repeatability of the measurements, then we have definitely improvement for the results. Next slide, please. Here we just start with data from our study. So it was, as I told you, cataract patients. The average age was around 62. Most of the patients were females. The biometry was just a normal average biometry, if you can see on this data for a standard cataract patients. And the target refraction was planned, as you can see here, always close to ametropia, and also with a very good reduction of the astigmatism, as you can see here. Next slide, please. If you can see here on the 1 month post-operatively data, you can see that there is already a very good uncorrected distant visual acuity 1 month post-operatively, which only increases slightly compared to corrected distant visual acuity, which shows us that we have really a very low post-operative refractive outcome, which is also represented here in the slides, as you can see on the right-hand side. So also, if we had a look on the axis target compared to achieved, you can see that in average, we are quite good, but there's also some outliners with up to 5 degrees difference from the target axis, which shows us that the optic design really works. So if we are also off axis a little slightly, we achieve very good clinical outcomes and very low refraction. Next slide, please. If we have a look on our uncorrected distant visual acuity compared to studies about the precision toric, for example, from Ferrara, you can see that our results really are comparable to other studies that also already exist. Next slide, please. Also, if we have a look on the accuracy 1 month post-operatively, the data show high degree of accuracy. We are in a large number in the close to the target refraction, and this is also comparable to the already mentioned study of Ferrara. Next slide, please. So we also asked the patient about their satisfaction, as you can see here. So most of the patients were highly satisfied, and we had no patients who were unhappy with his results, and all patients were spectacle independent for far distance. Next slide, please. Yeah, nightmares are always something we are concerned about. We had only one problem during the study. It was one of the very first eyes where we did the operation, where we had a defect of the haptic. I think this was because of the learning curve, because I was not used with this special kind of C-loop haptic, and I think I had a little bit problems with the injector in this case. But we could explant the IOL without problems and inject the standby IOL. There were no other adverse events. Next slide, please. Just something which we also do now in our clinics, since we use the Lensa flux platform for marking, which is very comfortable, because the interior axis concept and the cyclotorsion control of the system allows us very easy to bring the IOL in the axis. But what I will tell you is that in every case, I also use the RoboMarker, because I would like to have 2 ways for marking, because sometimes if the patient has a problem during the dental procedure, If there's any problem regarding the capsulotomy, then sometimes it's not possible that we have the marking if there is a suction loss, for example, and then I have always in the patient also the marking with a robomarker on the cornea, and I have no problems to bring the IOL in the correct position. Next slide, please.
Think about the time, Dr. Holland, please.
My take-home message. I think it's a combination of Cassini and the robomarker and the precision toric is a very easy combination. We don't need a special kind of a microscope for marking of the axis. It's very easy, and with the robomarker, and I think the study shows that toric IOL are easy to implant during our, and we can easily implant it in our daily routine for better results and happy patients. Thank you very much for your attention, and sorry for being a little bit longer than planned.
Thank you so much, Dr. Holland. It was a great presentation. Dr. Korkmaz.
Yes, I have maybe a few questions. Well, my first question is, you just slipped really fast about this dry eye disease. I did not understand the EI you were using. Is this some kind of IPL laser you're using? Could you explain this a little bit more? And in what place in your clinic does this dry eye disease treatment, in which position do you plan this treatment?
The EI is something like an IPL device, and we always use it in our practice preoperatively. And if there is a severe dry eye, then we also tell the patients we have to take time to make a better surface so that the measurements preoperatively are more accurate. And with this device, we make two treatments within 2 weeks, and then another third treatment after around 30 days. So we have to explain the patient that it will take a little bit time and that the operation will be a little bit later. But if you explain the patients why this is necessary, they easily understand it, and they are willing to bring a little bit of time for a better outcome. And they also notice very fast after the treatment that they really feel better with their eyes. I treated myself also with this device, and especially in the afternoon, my dry eye symptoms are really much better since this treatment.
Really nice to hear that you are doing something like this, because I know that when we are making or doing measurements, you see that the corneal surface is not regular, and then you put in a drop of lubrication, and then you do a measurement again. But of course, after surgery, the patient still has this problem of dry eyes, and if your measurement shows that the axis of your cylinder is shifting, then in real life it's also shifting. But with this kind of treatment, you will have a constructive solution, of course. Do the patients pay for themselves for this treatment extra, or is this in the insurance package in Germany?
In the general insurance company, it's itself. They have to pay it on their own. And if they have a private insurance, most of the private insurance companies pay for this treatment.
Okay.
Yeah.
Well, thank you both very much. We'll go further to our next speaker, Dr. Bosque from France. Dr. Bosque, are you with us?
Yeah, so thank you, everybody. So I'm really proud that you invited me to talk about challenging cases in toric implantation. So if we can start with the first slide of my presentation.
Yes, sir.
I'm a young surgeon. I work in Nantes in France in the Ophtalians group. It's the biggest private practice group of ophthalmologists in France. We do about 300,000 consultations a year. Last year we did 8,000 cataract surgery and about 600 toric implantations. For myself, I've been using the Ophtec Precision for 2 years now, and I did about like 130 implantation for the last 2 years, and I'm my only toric IOL I use in my practice. So for the tool we have in the clinic, I do work with the biometer from Zeiss with the IOL 500 and the IOL 700. With the corneal topography, we have a different tool like the Pentacam, also the Cassini, the Casia, and a simple topograph of a Topcon. I do use the online calculator from Ophtec, and also as Dr. Holland, I use the RoboMarker for every toric implantation. And actually, we are upgrading our operating room with the Callisto, but I think I will continue to mark the patient with the RoboMarker, also using the Callisto system. Sometimes if you have a problem, it's good to have a backup. So next slide, please. So one of the questions you can ask can I do the toric implantation if I don't have a Cassini, a Pentacam, a Casia, and I just have a simple topography? So in my opinion, the answer is yes, depending on the cases. To start with the cases of eye myopia in a woman of 72 years old with a preference for near vision, with a simple astigmatism. You can see the biometry and on the next slide, please. You can see I do for every cataract, even non-toric, I do a topography and a different topograph because it allows me to confirm the axis and the power of the cylinder, and also for the non-toric implantation, I choose if I make an incision in the superior way or if in the temporal way. So in these cases, the keratometry was concordant on the biometry and the topography. So I made, in the next slide, please. I made a calculation with the Ophtec calculator, and maybe just if you can see on the correction I planned, I chose my myopia between 2.5 and 3.0 dioptry. Usually for the myopic patient, I like to aim to minus 2.5, but just a little bit more is a little security. If there is a misalignment of the IOL of a rotation, so I can keep a result between -2 and -3 dioptry of results to get good functional results and to keep the near vision of the patient. Next slide, please. So if you see for this patient, I was really good with the alignment, and I just hit my targets. Also, for the myopic patient, I use from now systematically a capsular tension ring on eye myopic health, and I get better results since the beginning. I'm using the tension ring. If you can see on the next slide, please, another cases of eye myopia with another patient who wanted Hyperopia. On the next slide, you can see the topography, and in these cases, I had it was a patient that came from numerous years on the clinic. So I have a comparison, and the topography, as you can see on the right eye, is not so good. And if you can see, also on the left eye, and if you can see on the next slide, there is about 20 degrees of change on the measurement of the axis of the astigmatism. And for these cases, I did use the keratometry of the biometry because it was relevant with the previous keratometry I have in this patient consultation. So in the next slide, please, on the calculation, you can see I just chose Hyperopia, but at the same slightly myopic to avoid if there is a rotation to get in the hyperopia results of the patient and to avoid to have to make a lens rotation. Next slide, please. So the result in the refraction was not so perfect because there was still astigmatism. But as Dr. Holland said, sometimes you have a difference between the refractometry and the visual acuity because this patient had a very good visual acuity without correction. So I didn't have to make a lens rotation. Next slide, please. So in resume for eye myopia, I prefer to do smaller rexes than my usual because the lens is more stable. And if you have to make a rotation in a delayed time, for the example, I had the problem with the confinement. I had to make a lens rotation maybe 3 or 4 months after the implantation. If your rexis is too large, you will have on the sides where is no haptics, you will have the posterior and anterior capsule that will collapse, and it's a little bit difficult to make the rotation because you have to dissect the bag with a visco, and it's a little bit difficult. I use an intracapsular tension ring, and it's my way to deal with eye myopia. I like to keep the near vision for the patient, so usually I aim for minus 2.75 or minus 3 dioptry of myopia for this case. Next slide, please. So now I will talk about eye hyperopia and astigmatism with the cases of a woman of 50 years old with rigid contact lenses, and as you can see on the refraction trap, really high hyperopia and really high cylinder. So for this example, I didn't just use the anterior keratometry, so I did the biometry, as you can see on the next slide, of this patient with a short axial lens. And next slide, please. I am very lucky at the clinic because I have the Casia, I have the Pentacam, I have the Cassini. So I did a measure on the Casia and the Cassini. As you can see, I get almost the same axis and just a little bit difference in power of the cylinder. And so for this case, I chose the Cassini because on the other measure, I had the same power of the cylinder. And next slide, please. This is interesting cases. As you can see now, on the right, the Cassini measure, and you can see it's a measure of a pentacam that the patient had like 10 years ago in a pre-op of potential refractive surgery that she didn't do. And you can see there is a difference of 5 degrees of in the axis of the astigmatism. Sorry. So I also made a Casia on the left eye, and you can see I just like just the Cassini with almost the same axis, and also a difference in power of cylinder. And for the both eyes, sorry, I chose the Cassini. So it gave me next slide, please. It gave me a pretty big IOL, as you can see, with eye cylinder. And in my experience, the eye cylinder, you have much more risk of lens rotation if you are not in the correct axis, because the refraction will get bad, as we can see on the next slide. At the right eyes, at the first visit post-op, you can see the result was not so good with hyperopia, and the cylinder was bad, as the astigmatism was not corrected at all, and the vision was not so good. At the slit length, we could see a misalignment of about 10 degrees. Maybe it was a little bit more, but in my opinion, it was 10 degrees. So I did perform a IOL rotation in correct axis on the same day as the left eye, and as you can see, at the second day after the rotation, it was much more better. And at 1 month post-op, it was almost perfect. Next slide, please. And I didn't have the problem with the left eye, so the result was pretty nice. So for this eye cylinder and eye hyperopia, you have to make, in my opinion, almost 2 measures on different topograph, or the same but at different time, to be sure to be in the correct axis. Next slide, please. So now I'm going to talk about irregular astigmatism, because I do surgery, but I also do the contact lens adaptation in the clinic. And the question is, when can you do toric implantation in irregular astigmatism, or when do you decide to just do the phaco and to keep the contact lens in the post-op? So I will show you 2 cases of irregular astigmatism. The first is a woman of 73 years old who wears bifocal rigid contact lenses with not a big ametropia, and she's really exigent and she wants to get rid of glasses on the contact lens. So on the first topography, on the next slide, please, you can see there is an irregular astigmatism predominant on the left eye. So on the next slide, please, I also did a pentacam from this patient, and you can see it looks much. It's not so bad as on the previous topography, and you can see the left eye on the next slide. There is a difference, but I tried to put a toric IOL. So if you can see on the next slide the calculation. So maybe what we can be discussed in this case is for the calculation. I did use the new calculator from Ophtec with the Abulafia-Koch regression, and maybe it would have been better to use the true K. So I always do for my toric implantation to choose a little bit to be on the myopic side of the post-op to have a little bit of security. And in the next slide, please, you can see the refraction was not so bad, and with a really good uncorrected visual acuity. And what was nice that she could still read without glasses and without the contact lens. So in this case, it's a good functional result.
Think about your time,
next
please,
slide,
Dr.
please.
Bosk.
Sorry.
Okay.
Okay, I will go a little faster. So it's a patient with also irregular astigmatism, much more important. So you can see on the next slide why I do topography is you can see the cylinder on the right eye on the biometry, and on the next slide you can see that on the CASIA and the topograph the power is completely different. So this is really important to make sure of your measurement, but in my opinion, sometimes if you have not so good results, it's not in the surgery, but before you had not the good axis of the good cylinder. So you can see on the next slide, the left eye, it was more relevant with the biometry. And on the next slide, you can see what we did as a surgery, and the result was really good on the far vision and pretty good on the near vision. So in irregular astigmatism, when I don't put toric implantation, it's for a corneal graft with really high astigmatism. And if I plan to do a scleral contact lens or a rigid contact lens, because if you do that, and I had the case from other patients, you will correct the corneal astigmatism with the contact lens, and you have to deal with the internal astigmatism of the IOL, and you have to put an external toric correction on the contact lens, and it's really difficult to do because you can have a rotation with the eyelids. So I do use in irregular astigmatism on the moderate astigmatism and with the patient who wants to get rid of contact lens with a bad tolerance. On the next slide, it's to conclude, it's also a really good result with the piggyback trifocal implantation when I am hesitating on the patient and you're not sure on the result of multifocality. For this patient, I did a surgery on the next slide, please. Sorry. You can see the calculation of the lens with a small cylinder, but I'm not so fan of the toric multifocal IOL. So I just did a surgery with the toric Ophtec. And on the next slide, please. I did in the second time a bilateral trifocal implantation, and the result was really, really good. On the next slide, please. Sometimes with these implants, you don't need a piggyback, as this patient with hyperopia and astigmatism, who did drive a lot, so even at night. So on the next slide, you can see the biometry with really high cylinder, and in my opinion, it's not a good indication of a multifocal IOL. So on the next slide, you see the topography of the right eye and of the left eye on the next slide. And on the next slide, you can see the plan of the surgery with the toric. And I'm stopping, sorry. And then the post-op was really good with no need for implantation. So maybe we can just go to my take-home message, please. And on the pre-op, you have to be careful the measurements. I take the first negative power of implantation. I don't overcorrect the astigmatism. I start with the higher astigmatism of the eye, and you have to be careful with the contact lenses wearer. And the pre-op, I do recommend a robomarker on the Callisto system. Small, not too big for the rexis in care of future rotation, and I do use CTR for high myopia. And finally, on the post-op, what's important is the subjective and functional refraction. I don't hesitate to make a early lens rotation if I'm not good. And also, I get very good results with piggyback trifocal implantation. Thank you for your attention, and sorry for being long.
No problem, no problem. Thank you so much, Dr. Bosch. A lot of interesting cases, and there are some questions from the public, from the audience, which Dr. Korkmaz is going to translate.
Yes, Dr. Bosch, thank you for your presentation, and it's nice to hear that even though we are miles or kilometers apart from each other, that we are using same techniques. So you use low-tech in the form of course it's not really low-tech, but in the form of the robomarker in combination with the Callisto, the high-tech part, and that you can always have a backup. I also had a few questions myself, maybe with a simple answer, and then I will have a little bit more complicated question. How do you measure your misalignment? So what kind of measurement instrument do you use?
Usually I do use for example, for the eye cylinder, I have the refraction. So I have a trick if there is still astigmatism and I'm on hyperopia, I know that I'm not so good. And usually I do use the slit lamp with the axis, and it works pretty good. So
okay.
I didn't. I'm just with the slit lamp generally.
Just with the slit lamp. Okay. There's a really nice app. It's by a Spanish ophthalmologist. I think he invented Access Assistant, and it uses the gyroscope of your iPhone. But I can, in a personal conversation, I can explain it to you. But I have a little bit more difficult question from Tiago Montero. And he says it is clear that he chooses always the toric power that always overcorrects the cylinder, and it looks he is not taking into account for the posterior astigmatism according to the Baylor nomogram. Could you explain why you do that?
Sorry, I just didn't understand the question. So I'm not taking the...
Well, this colleague asked that you are always using the toric power that always overcorrects the cylinder, and it looks that you are not taking into account the posterior part. Is that correct? Or can you explain why you do that?
For the posterior cornea, I start, maybe I'm not, so I will try to explain. So at the beginning, we had the Cassini, so I made all the measurement with the Cassini, and also I made a comparison with the Cassia. And from it appeared that there was not so many cases where I had a difference between the axis of the astigmatism with the Cassia and the Cassini and the simple topography, mostly in the oblique astigmatism. So it's depending on the location. I'm making the consultation, but because sometimes I don't have access to the Cassia or the Cassini devices.
Okay.
And this is it.
So it's not your usual practice to never use or take into account the posterior cornea, but it only when you have the possibility of the Cassia or the Cassini, then you do it. That if that's a wrap up of your question, of your answer. Okay, thank you very much.
Do you have one last question, or you're okay?
No, well, I saw some remarks coming by that people are doing a rotation when the misalignment is larger than 10 degrees. But isn't it that it's better to do a rotation of a lens when you're just taking your post-op refractive power into account? So if it's not aligned exactly on the axis you were planned, shouldn't you then just take a look at what the post-op refractive error is instead of the misalignment? So I saw these remarks coming by. Do you agree with that?
Yeah. Yeah, you can, but sometimes if you see at the second day that there is really a big problem, especially with like you are in a 5 dioptry of astigmatism, if it's not so good on the first day, you won't have the effect that you want. So I make the correction in early post-op if I'm sure there is a misalignment. And if I'm not so sure, I'm waiting for the first month to make the rotation. It's still easy.
Okay.
So,
and if you use the if you're looking at your axis, do you then try to rotate to the actual axis you were planning to do first, or do you choose another axis?
Usually, I do make the rotation on the axis I initially planned.
Even after you have probably caused some surgical induced astigmatism.
Normally I'm not so doing so much astigmatism on my incision because I'm used to make really some posterior incision and not so in a pretty direct incision. There is not so much induced astigmatism.
Okay. Thank you.
Thank you both. Thank you very much. We will go now to Professor Filomena Ribeiro from Portugal. Are you there with us? Can you hear us?
Yes. Hello, Tiago.
Welcome.
Thank you to Ophtec for inviting me to be here. And if I have my slides already?
Yes.
Yes. So I'm glad to talk to you about this new concept of a PCIOL, which is the Precision Presby and VA. And next slide, please. And we all agree that the correction of presbyopia right now is like the holy grail of cataract refractive surgery. Next slide. And we always must keep in mind that the presbyopia, it really is a chronic dysfunction. and it has impact in our quality of life. And if you see this study, for instance, show us very well the effect of the near visual impairment on quality of life is more compared from distant visual impairment when we talk about domains like physical, physiological, and social. So it really is a big issue to treat presbyopia in cataract surgery. Can we pass the next slide, please? And a little bit about the evolution of the PC IOLs. We all start with the bifocal IOLs, but right now, if you change for the other slide, we see that the trifocals and the EDOF IOLs are the most used PC IOLs. And next slide, please. Well, we start with the bifocals. Like trifocals, they are a simultaneous vision principle. The EDOF, it's another concept of continuous focus. Next slide. And with the bifocals, what we have learned is that the patients complain about not having enough intermediate vision. Also, we saw that if we had more ED for near, we had more halos. So bifocals transform in trifocals. And next slide. And right now, we can use bifocals in a mix and match concept or because of the economic issues. But the more prevalent IOLs, next slide, are the trifocals and the EDOF. With trifocals, we can privilege near vision. The classic trifocals, they all repart more light for far and then near, and then the last trend of light is for intermediate vision. The EDOF concept privilege more the far and the intermediate vision, and as you know, they are more tolerant to residual refractive error. Next slide, please. But the intermediate vision relevance for our daily tests is huge. And we can see that with all that kind of EDOF concepts, new concepts that emerge in the IOLs that we have right now. But also, next slide, we see right now, you can change the slide, that even monofocals and trifocals are trying to deliver more intermediate vision, because functional vision is very relevant for our patients. Next slide. So in this context, we'll talk about this new refractive IOL, the precision presbyopic NVA. Next slide, please. This IOL is a hybrid hydrophilic and hydrophobic acrylic material. It's one-piece IOL. It's very similar with the toric precision that we saw before. He has a spherical design, gives a negative aberration to compensate for the spherical aberration of the cornea, and has this multiple segment refractive optic with a power head of plus 275. We can pass the slide, please. So what really makes this lens unique? This lens has multiple segments for near and far with an asymmetrical distribution, but also very relevant that these segments, they have a very smooth transition, and these provide the intermediate vision. So we have a continuous transitional focus between the far vision and the 40 centimeters. We can pass the slide, please. Another concept that really is relevant with this IOL, we need to address this issue because pseudophakic eye is not a centered optical system. We know that. We know that the mean optical decentration between the visual axis and the center of the IOL can be about half a kilometer. And this is relevant because we know that at least in 10% or more of cataract cases, we have a decentration of more than 1 millimeter. So this IOL, we can pass to another slide, please. With this multi-segment asymmetrical concept, can be more tolerant to the issues related with angle kappa, also with decentration of the IOL, and could be more pupil independent. Next slide, please. This NVA model is the second model for the precision presbyopic. It has some difference related with the first design. Right now we have a part of light more for far than the first design, and also, as I told you before, we have a negative aberration concept. Next slide. Also, the center of the lens is for far vision, and we see that change a little bit the dimensions on the horizontal and vertical dimension. Next slide, please. What I want to show you is the results that we have. We enter in the European multicentric study of this IOL, and we have this schedule examination table that you see here, with all the visual acuity, the refraction, the sensitivity, contrast sensitivity, the focus curve, all the biometric values were measured, and the pupillometry, also because of this concept of independence of the pupil. And we also have some questionnaires of the patients. Next slide, please. In this slide, we see the demographic data, the distribution of the IOL powers for our group implant lens. As you can see, we have some dispersion of the IOLs. Next slide. About the same for all the group, as you can see in the left table, more or less the same distribution of IOL power. The actual length of the patients could be a minimum of 21 and the maximum of 29 in the old cases. Also, with the big difference between the minimum and the maximum of the anterior chamber depth, as you can see, and also for the pupil diameter, in photopic and topic. We can pass the new slide, please. And about the results, our refractive results for our patients, as you can see, we have an incorrect distant visual acuity. I have some sounds for the room. Okay. Okay, we have the refractive results here in this table, as you can see, with the cumulative Snell visual acuity very, very good. And also for the spherical equivalent refraction accuracy, very good, with 100% of the cases of less than half of the diopter. We can see another slide, please. In this slide, we see the more relevant results, the binocular results. In this case, for me, is the more relevant. For all the group we have here, how the results are stable in time, between 1 month, 3 months, and 6 months of post-op. In the right, you can see the graph for the binocular, the focus curve. As you can see, and if we make here the equivalent in the 0.1 logmar, we can see that we have between +1 and almost minus 2 and 75 diopters, we have this value of logmar. If we see for the 0.2, we can go even to -3 diopters. So a very good the focus curve, and also with a broader zone here, which give also to this IOL some tolerance to refractive residual error. Next slide, please. In this slide, we see the results on contrast sensitivity in mesopic and photopic conditions, and also with the association of glare. You can see very comparable to another kind of multifocal IOLs. The next slide. In the next slide, we see a relevant issue, as we know, for this kind of IOLs, the dysphotopsia. And in the left side, we have the results of our group for the bothersome of the photopsias that we have here. And in the right, we have, of course, is not the same population, but is the results that we have published for 2 different diffractive trifocals. And if we compare, we see that really the precision has very good results concerning this photopsia. Next slide, please. And also for spectacle independence. This chart shows us the independence of glasses of our patients. Next slide. And right now, I will show you a short video of the implantation of this IOL. I hope you are seeing, yes. So, as you can see, the platform is very, very similar to the Precision Toric. It's very friendly to use. It's an IOL for small incision and very easy to implant. As you see, the C-loop haptics, they give this IOL a very stable condition, and this results in the stability of the refractive outcomes of this IOL towards time. As you can see, it's difficult to see the transition between the multiple segments in the optic of the IOL. Very stable platform. So we can return to the presentation, please, just to give some conclusions. And my conclusions with this study that we have done is that this IOL, the precision presbyopic MVA, give us very good refractive results at all distance. The focus curve shows us how this IOL can provide very good functional vision for our patients with a low incidence of dysphotopsia when we compare with diffractive multifocal IOLs, and also retrieving a very good independence from glasses. And next slide, just to say you thank you for inviting me to be here. Thank you so much.
There are some questions from the audience and some questions from Dr. Korkmaz.
So, Professor Ribeiro, thank you for your nice presentation. I have a question for you. Do you have changed your cutoff rate of your alpha kappa when started using the NVA Presby? Have you changed it, or do you still stay on the same cutoff rate that you used before Presby was on the market?
No, not really, because with this IOL, I don't have this problem. And if I have this problem with the couple angle, we can always implant the presbyopic NVA. It's more tolerant, so for that kind of cases, it's a very, very good option.
Because in that case, I also have a question of a colleague of mine. It is Dr. Stefan Koppens here from the Netherlands. And he asked that due to the orientation of the far near segment of this NVA lens, does it make difference in which orientation you implant the precision presbyopic? In other words, he says, do you want to place the central far vision segment in a horizontal way?
No, not really, not really. It's not relevant. If you see the design of the optic of the IOL, the asymmetric distribution of these multi-segments doesn't concern how is oriented the implantation of the IOL. It's not a problem.
Okay, because in my practice, when I use the NVA Presby version 2, I tried to put a horizontal part of the bow tie in the direction of the alpha kappa to try to have a larger spread of the far vision.
Yes, but
do you have an opinion about that?
With the improvement of the center with these two versions of the IOL, the dimensions are different right now. So with this model, I don't think it's a problem.
And having this experience with the NVA presbyopic, are you still using other kinds of multifocal lenses, or do you only use the NVA Presby?
Okay, I don't think we can have a universal presbyopic correction IOL right now. Okay. So of course I use different kinds of IOLs, but the precision presbyopic IOL is a very, very good, retrieves very good outcomes, and patients are satisfied without this photopsia. So if you are concerned about issues related with dysphotopsia for drive night conditions, for instance, it's a very good option, but it's not universal.
I understand. And is there just one particular reason why you should not implant the Presby?
Well, sometimes we need to provide more near or provide more efficient intermediate vision. And for that cases, I can have another kind of solutions.
Okay. Thank you.
Very good. Thank you very much. Before we close and we wrap up, I would like to find out if Dr. Mulder is online.
Yes, I am.
From Tallinn, Estonia. How are you doing, sir?
Very well.
Hi, welcome. Dr. Mulder is based in Tallinn, and he has a vast experience with multifocal IOLs throughout his career. But I understood that he also had surgery done not so long ago. So Dr. Korkmaz has a few questions for his colleague in Estonia.
Yes, Dr. Mulder, welcome to our webinar. And I'm really pleased to meet you in this manner. And I'm really curious about your answers of my questions. Because of your experience, and you're a cataract surgeon yourself, How did you choose your own cataract surgeon? On what kind of preferences?
Well, there are many good surgeons in Estonia, but I contemplated to have my surgery for a couple of years, and I thought that the best surgeons hadn't any experience with NVA. So then I get to know that they have some the precision platform. Then I decided to have the surgery.
Okay. And you preferred this multifocal precision presbyopic, and could you tell us what the reason is that you choose for this actual lens?
Okay, I have implanted multifocals in 15 years. Started with bifocals, and the advent of trifocal was a great thing for me. And then I implanted my first presbyopic, precision presbyopic NVAs in 2000, the end of 2018. Then I noticed right away that if you look at this lens under the slit lamp, the lens looks very natural. And then I thought, wow, maybe it's the other way around also. The patient sees the world in a more natural way. And then I have to admit, I haven't had any statistics done among my patients, but I developed a strong feeling that say in 1 month's follow-up, there are many more patients after NVA implantation who don't have any complaints whatsoever compared with other multifocals.
Okay.
NVA came with a promise that there are no halos or very less halos. I don't agree that there are no halos or dysphopsias, but still, I choose that because I feel it's the best at the moment.
And how is your far intermediate and your near vision at this moment?
I'm doing very well. My distance vision is perfect. Intermediate, I'm still amazed that I can cook without glasses. And my reading, it's my 6th week after the operation. And well, I have to admit that my contrast sensitivity has gone down a bit since the 2nd week. I can do very well, but it was better in second post-op week. I guess it's a common knowledge among the cataract surgeons that multifocals are extremely sensitive to PCO, and I have some.
Okay. And how does it affect your surgery performance? Because you're still doing surgery, I guess.
Yep. Well, I performed my first cataracts at my 5th day after my own surgery.
Wow.
And in the beginning,
wow.
Yeah, and in the beginning it was strange. I could see very well, and my impression was that perhaps I can see too well. So I could at the same time when I was performing capsular rexis, for instance. Sort of feeling that I have very good operating microscope, but it's a bit strange. But now this feeling has gone, but I do very well, and I am not afraid of capsulotomy in the future. So for me, the important thing is that I have felt very well or seen the potential of this implant for the 2 weeks, say. Now it's a bit less for intermediate and reading, but no problem.
There's time for one last question.
Well, I don't Have any questions? I think
Okay.
he's really courageous to have done cataract surgery on himself, and I'm really glad that that he wanted to share it with us.
Yeah.
And of course, there is no perfect lens at the moment, because otherwise everyone in the world would implant this perfect lens. But maybe you chose the near perfect lens in the form of the NVA Presby.
Very well. Thank you very much for sharing your experience, Dr. Mulder. There's one question from, thank you so much. There's one question from the audience, which I will answer myself, and then we will close the day. And there is the question is, when will precision presbyopic toric be available? Well, I can tell you that it will be available the second quarter of 2021. So we just have to wait a few more months to start with the sales of the product. So we're very excited about that, and I hope you will be excited about that product too. So once again, thank you everybody for being here. Thank you, Dr. Bosk. Thank you, the Professor Filomena, Dr. Korkmaz, Dr. Mulder, and Dr. Holland as well, for being here, and thank you, of course, for the audience. There were a lot of questions that could not be answered. We will try to answer them and email you back, so you will hear from us again. Once again, thank you very much.
Thank you.
See you.
Thank you so much. Bye. Bye, everyone.